So hello everyone, Jan Sloves here. I'm going to walk you through this slide set entitled, When Should You Duplex Both the Lower Extremity and the Pelvic Veins? This is an important topic. I live in this arena every day as patients come in, and I have to apply both of these examinations. So with that, I'm going to walk you through the guideline-based indications for combining both of these exams. Again, these are all out of the recent guidelines, and they're online for you to check out. Now, as the guidelines suggest, we want to combine both examinations in all symptomatic patients suspected of acute iliofemoral DVT. Now, the goal here is to define the proximal extent of thrombus into the iliac veins and/or IVC. As we know, this has a major impact on anticoagulation strategy, thrombolysis planning, and the overall management of the patient. Certainly, the associated clinical indications, a patient's going to present typically with unilateral swelling and groin and thigh pain. I also want to recommend, and I feel strongly about this, the use of the common femoral vein pulse Doppler waveforms. I routinely, in all of these exams, use it as a screening tool. And when these parameters are optimized appropriately, you can see the obvious changes in the asymmetry and the loss of phasicity. And certainly when that's apparent, that is consistent with there being an obstruction above, and very important to get a good look. Certainly in the more severe cases like phlegmasia, again, you never want to miss any sort of iliocaval involvement. It can certainly delay life-saving intervention. The guidelines suggest that we combine both exams in all symptomatic patients suspected of iliocaval outflow obstruction. So the goal here is to define non-thrombotic and post-thrombotic lesions and the extent of collateral veins, and there's certainly other causes too. And these are the patients that are coming into our labs every day. They have skin changes, they have heaviness, they have venous claudication, severe edema or ulceration. During the physical exam, you want to check for suprapubic or abdominal wall varices, certainly when that is consistent with there being obstruction. Should you have a patient with unexplained unilateral swelling with a completely normal infaringuinal duplex examination, again, on the pretenses that there's got to be a reason, you want to have that ability to go up into the pelvis and get a good look there. Now, the guidelines, they also suggest combining both exams in all symptomatic patients with suspected pelvic venous disorders. Now, the goal here is straightforward, to define reflux and obstruction in symptomatic patients. And we know many of these patients, they can be quite challenging nonetheless, but they need to be investigated. Certainly during the physical exam, should you see medial thigh, vulvar, perineal, gluteal varices, well, that alone is telling you that you've got something going on above. There's reflux and obstruction. And again, you want to do your due diligence and investigate it. If you have a male patient who presents with dull, achy scrotal pain or heaviness, and it's worsened by standing or exertion, certainly this would be consistent with a varicocele, and of course, it would need to be worked up. We also want to combine both examinations in all symptomatic patients with chronic venous insufficiency or recurrent varicose veins. The goal here is straightforward, define reflux and obstruction. And these are patients, again, with a severe SEEP, right? So we're talking 4, 5, and 6, and where the symptoms will exceed the distal pathology, right? Should you have a patient with recurrent or persistent varicosities, particularly in the medial thigh, vulvar, or perineal distribution, again, you want to think pelvic leak. There's got to be something going on. You want to combine both of these exams. If you have a patient that presents with unexplained chronic swelling and you did a very thorough, deep, and superficial standing reflux exam and it's negative, again, and as long as that exam was done properly, again, going on the pretenses that there's got to be a reason, you want to look higher and investigate this. We also want to combine both exams for all follow-up post-intervention. Now, the goal here, again, straightforward. We want to evaluate the inflow of veins in these patients, define stent patency, and do a good assessment of the outflow veins as well. And certainly, if you have a patient that presents with persistent or recurrent symptoms post-intervention, again, you want to do your due diligence. You want to have that ability to scan both examinations and put it together and answer clinical questions. We certainly want to combine both exams in all symptomatic patients with unclear or conflicting findings. So should you have a patient where the symptoms persist despite a normal lower extremity duplex, or pain and or edema, which is completely disproportionate to the distal findings. Should you have a patient that presents with a venous ulceration and you have an inconclusive duplex exam, and it should be noted that greater than 30% of ulcers, now it's correlated and the data is out there, they have an iliocaval obstruction. So again, combine both examinations. So with that, I want to just show you a couple of mini little case studies to bring in these points that have been made. So here's a patient, 55 years of age, breast CA, undergoing chemo. She's got a symptomatic right leg. And when we did our lower extremity evaluation, she's got acute DVT, femoral common femoral down into the popliteal and the tibial vessels. So the next step is to define the proximal extent. And here we can see how the thrombus wraps around the femur head into the external iliac vein up to the confluence. And it should also be noted that about 80% of patients with iliofemoral DVT will have a more proximal stenosis. Next case here involves a 52-year-old female, left-sided PTS. She is definitely symptomatic. She's got significant femoral popliteal obstruction as well. And when we look above here in this patient, we can see that we got these large collateral veins. They actually extend through the pelvis into the abdomen. She also has chronic total occlusion of her external as well as her common iliac vein here. And this occlusion does extend into the distal portion of the cava, where additionally there's a collapsed filter. And then this last case involves a 70-year-old gentleman. He's got a symptomatic right leg. His history is consistent with prostate CA, and he was treated with radiation. He did have a negative DVT study. I did find here a continuous wave pattern here at his right common femoral. And typically when we have this finding, this is consistent with obstruction. So I changed transducers and looked above here, and we can see that there's a very focal, tight stenosis here of his proximal external iliac vein. He's got a continuous flow pattern through this area with 107 centimeters per second and his peak vein velocity here. And when you put this together, it's consistent with radiation-induced phlebitis. So in conclusion, and as the guidelines state, combining both the lower extremity and the pelvic vein duplex, it is certainly indicated for all symptomatic patients where obstruction or reflux or both is suspected. You do want to avoid routine duplex surveillance in asymptomatic patients to prevent unnecessary testing and overtreatment. Adhering to these evidence-based criteria certainly will enhance his diagnostic accuracy, optimizes outcomes, and will conserve healthcare resources, which is all very important to us. So with that, thank you so much for tuning in to Ultrasound Unlocked, and I hope to see you on the inside in the community very soon.